This is going to be a quick kind of a case-based discussion over 5 or 6 cases that we have chosen from what we have now a vast repertoire of more than 250 odd operated cases over the last 27 years. So the first case is a 64-year-old gentleman, South Indian gentleman, non-addict, who had recurrent abdominal pain radiating to the back, multiple visits to the ER for analgesia, overall history of roughly around 6 or 7 years, and came with the USG features suggestive of chronic pancreatitis with a dilated pancreatic duct. Of course, was seen by a surgeon to begin with, but let me rope in the medical gastroenterologist out here. Ankit, what would be your next mode of investigation for this patient? Would you want to do an MRCP? Would you want to do a CT to begin with, or an endoscopic ultrasound? What? How would you investigate this patient further?
So we do a lot of endotherapy for chronic pancreatitis in our department at Global. So when such a patient would come with recurrent abdominal pain and ultrasound showing features of chronic pancreatitis, the next step for what we would do is do a CT as well as get an MRCP, both investigations. It would be helpful if the ultrasound showed some stones, or if the report was more conclusive, because we do a CT to quantify the radio density of the stones before proceeding for doing extracorporeal shockwave lithotripsy. So we would do CT with contrast and an MRCP both at this point. To assess.
So there you are, Ankit. I have given you the MRCP now, which shows a grossly dilated pancreatic duct with an atrophic pancreas. Yes. The duct was of roughly around 6 centimeters in size. Honestly, we have never seen such a large duct. And there were 2 pseudocysts in the body and tail. What next? Do you want to investigate further this patient, or would you want to kind of intervene? He obviously requires interventional therapy because he's totally symptomatic. I mean, would you have any differentials for this, whatever you're seeing on the screen, or you think you're convinced with the radiologist's report, or that this is a grossly dilated pancreatic duct?
So the other differential that needs to be considered in this patient would be an IPMN, obviously, which is presenting with recurrent episodes of abdominal pain and hugely dilated duct. I don't see any stones here, obstructing stones in this MRCP. So possibly this patient has a very tight stricture in the, so there are calculi, So so this patient requires intervention. I would like with calculi with such a huge dilated duct, it would be prudent to intervene by doing a ERCP and ductal extraction of the stone.
Would you be concerned of what you're seeing out here? Something out here, an outpouching also? Yeah. Would you be concerned whether this is related to the CP, or do you think that this could be some additional kind of pathology there sitting in this patient?
So that's what. So with such a hugely dilated duct, I guess I would have done an endoscopic ultrasound to assess this cyst, and perhaps take a sample from this cyst if it appears suspicious for a cystic neoplasm.
Okay, I think that's a good point. We unfortunately did not do an endoscopic ultrasound out here. Yeah, Paresh. Any thoughts on what's going on the MRCP and the CT, and what next from your end, or anything further? Would you want to investigate this patient any further?
Well, personally, I have not seen such a ductal dilatation at all. The largest I have seen is 3 to 4 centimeters, and this looks pretty large. Additionally, as you rightly suggested, there is some neural nodule or thickening in the body tail region or proximal body region. And in that area, I'm a little suspicious of something happening. So with all this background, I would suggest that endoscopic ultrasound would be very useful in trying to elucidate that.
Okay, thanks, Paresh. So yes, endoscopic ultrasound was considered, but for some reason we did not do it. In all probability, because he was already investigated, and there were some reservations from the relatives, as often happens with our patients, as to how much to investigate. So anyway, we did not get an endoscopic ultrasound. I think I'll skip that slide. And this is what we did. And there were stones out there. I mean, the MR or the CT showed a solitary stone, but there were a few stones out there. And as you can see, a hugely dilated duct. We did a phrase head coring procedure with a pancreatic jejunostomy. And those so-called mural nodules were nothing but just a dilated duct that was so large even in the body that it had actually was almost about to rupture. So it was just the part of the duct that had probably kind of eaten up the body completely and, had dilated to such an extent. So an unusual case, with such a hugely dilated duct. 6.2 is an extremely dilated duct. One of the problems we were wondering was whether there is also a malignancy, because normally the larger the duct dilatation, the more chances of malignancy being there. We also were not sure at this point whether there is an IPMN harboring somewhere. Anyway, at the end of the day, this is what we did, and he had a follow-up after around 6 months where we got a sonography done, and to our pleasant, I wouldn't say surprise, but I mean, it's always good to know that the duct had now reduced to around 5 or 6 millimeters over a period of 6 months. So, a lot of times I keep on saying that the proof of the pudding is in its taste. So that's what it was. And of course, I think I won't go into this details on this slide because Ramesh has already covered principles of surgery. But I think one needs to evaluate what procedure to apply for a particular patient. So I think that's where the key is, resectional procedure versus pure drainage procedures. So. Okay, let's get on to the second case. 53-year-old gentleman, again, non-addict, recurrent abdominal pain for a few years, diagnosed as having chronic pancreatitis, on medical line of treatment, non-diabetic, steatoro managed with enzyme replacement therapy. Again, I mean, we are back to the same question. What do we want to image now? Do you want to get in an already established patient of CP directly an EUS or an MR or a CT? Dr. Paleswan, your thoughts on this? How would you proceed at Tribhuvan University in such a scenario?
Thank you very much. At Tribhuvan University Teaching Hospital, we would go for CT scan, our first line of investigation in a patient with chronic pancreatitis, whether it is for the first time or we are reviewing it again. We prefer to go with contrast and CT scan with pancreas specific protocol.
There you are. We have a CT for you of the same patient who has a large 8 by 6 centimeters pancreatic head mass with small cystic areas, right. Dilated, very dilated duct around 7 millimeters, and marginal lower CBD narrowing. As you can see in the plain scan, there is no obvious calcification anywhere, not even specks of calcification. Right. Amar, yeah, I'm sorry. Please go ahead.
That's okay. As you said, there are no calcifications, and the intrahepatic biliary ducts are also not dilated.
Correct. Amar, any thoughts on the CT? What comes to your mind? Benign pathology, malignant pathology?
So it seems that the duct is passing smoothly. The vascular structures, they are also fine. And there is no perivascular, peripancreatic pain invasion by the lesion. So it must be an inflammatory mass rather than a malignancy.
Okay. Mehul?
So basically the question is that whether we had a imaging in the past, because the cystic areas and this type of a malignancy which we are suspecting. Oh.
Yes. So correct. So there was a CT scan that was there in the past, around a year and a half old, which showed more or less the same picture. Maybe a few cystic areas that were additionally seen in this CT scan as compared to the previous one.
And
there was no other intervention done. There was no endoscopic ultrasound, no MRCP. This is what we advised when we saw the patient. Do you think anything further needs to be done? Do you want to get an endoscopic ultrasound here? You want to stick in a needle and see?
So we ask for the tumor markers, and then I would prefer doing an endoscopic ultrasound guided fine needle aspiration biopsy.
Right. I think again, one of the things that we always keep on, wondering how much to push and how much do we investigate. Endoscopic ultrasound, of course, is I mean, it's no more a new kid on the block. It's been there for a while. Does give us a great amount of information. We would use it judiciously, honestly, as surgeons. If there is some semblance of a suspicion of malignancy on CT or with raised tumor markers, we would then, of course, go to a little more lens to kind of, push the envelope a little further, get more investigations done so that we are clear what we are dealing with, whether it's benign or malignant. But in this thing, I think, as Amar clearly said, and we were also fairly convinced that this is a fairly benign head mass, and certainly needed attention. Paresh, what do you think would be your options in this patient?
I would also like to know whether the patient had jaundice at presentation.
No, he had just a marginally elevated alkaline phosphatase, but the bilirubin were normal. There was no intrahepatic biliary dilatation as can be seen in these cuts of the CT scan. I'm sorry, unfortunately, in meetings like this, we cannot have the entire CD playing. So this is what...
That would be one more important point, which I would like to correlate in case I'm suspecting a malignancy. So
Correct.
the point is well taken that on balance, it looks like an inflammatory head mass. And if that were to be so, it depends how much you want to push the envelope. And perhaps I would also agree with you that in this patient, I may not insist on an endoscopic ultrasound with a FNA because the yield, first of all, is very limited. Having said that, then this patient would be subjected to surgery, and one would like to do a resection and drainage combined procedure. And the procedure which we choose, or I choose personally, is a Frey procedure, which is a head covering. And the important point I would like to share to the younger surgeon is to consider a generous Frey procedure and a judicious head covering, such that we address 2-3 important principles of the head covering. One, we all know that the head mass itself is the pacemaker, or there is a theory proposed as the pacemaker. So we address to try and decompress that head completely to remove the source of pain by unroofing the main pancreatic duct, unroofing the duct to the uncinate, and also to the minor pancreatic duct. So once you do a generous head covering, you also extend this head covering with the lateral pancreatodocotomy. And finally, this shell of the pancreatic head and the duct is anastomosed to the side of the through loop of the jejunum. So in other words, this is a resection cum drainage procedure. And this is indeed a limited resection compared to the aggressive resection, which is a pancreaticoduodenectomy.
Correct. So actually we were...
Just comment?
Yes.
Hi, sorry. So just 2 points. The role of endoscopic ultrasound as we discussed. So firstly, the yield of tissue has dramatically improved with the newer needles. Now we no longer use aspiration needles, we use biopsy needles, which gives us core tissues, and we can, in fact, most of our patients at our center, we just use biopsy needles, which gives us good cores of tissue, like doing a true cut biopsy. And you can do immunohistochemistry on such patients, and you can do the tumor, whatever, IHC staining for IgG4 cells or etc. So, such inflammatory lesions do.
So do you do IHC for ICG in every patient that you pour out?
No. So as you said, so this looks like a benign mass. So a benign mass forming lesion is an autoimmune pancreatitis. The first differential would be an autoimmune pancreatitis.
Not really, Ankit. No, I don't think I would agree on that. Autoimmune pancreatitis is not very common in India. That's first thing. It would be the last thing on my mind. The classic type 1 lymphoplasmacytic pancreatitis, of course, which we were one of the first to report again 15 years back, has the classical sausage shaped, no calcification, non-dilated ducts. So here you had a dilated duct in this patient with the head mass, which at that point of time, with this of course case is fairly old, did not fit into type 1 AIP kind of thing. Of course, we were pleasantly surprised when the pathologist did call us up and said that this to me looks like a duct-centric lymphoplasmacytic infiltrate, suggestive of AIP type 2, correct? Which we had never heard, so honestly.
No, so type 2 is a mass-forming autoimmune pancreatitis, whereas type 1 is the sausage shape that you classically described.
Correct.
And I will say, So the role of EUS does exist, I would say, because of this, that any patient who has a mass in the head, before undergoing surgery, it is prudent, in my opinion, to undergo a biopsy, because literature says that almost 10% of these patients end up having an inflammatory mass, either related to autoimmune pancreatitis or benign inflammatory mass. So, and especially with the needles that we have, we can get good core tissue. So the diagnosis is not in doubt right now. We
No,
get,
indeed,
really good
I
core
get your
tissue. So
point. I get your point, Ankit. But as I said, we have to be a little judicious about the use. It's not always possible to subject every patient that comes to us to, subject it to an EUS, unless we're suspecting either now an AIP or a malignancy. To be on the safer side, we need to know what we are dealing with. I think those are good cases to stick in a needle and take a biopsy. Anyway, I mean, just briefly, as you can see, type 1 and type 2 AIP. And of course, we reported this case as the first one described from India in 2017. Autoimmune type 2, first report from India. I think it was published, Gunjan and Prasad, 5 years back. And of course, the thing about AIP type 2 is that you can't even treat these patients with steroids. They are steroid resistant. So the best option, the early reports that came from Japan said that the best option was a surgical resection or a surgical treatment, and you don't even need to put them on steroids after a surgical resection. Okay, let's move on to the next case. 38-year-old gentleman, persistent left hypochondrium pain, presents with left upper quadrant fullness on examination, palpable spleen, moderately enlarged, couple of finger breadths, the fingers below the left margin. CBC shows leukopenia, thrombocytopenia. Dr. Lakhe, how often do you see this kind of a picture in patients of chronic pancreatitis in Nepal? Is it fairly common to have patients presenting in such a way?
Not very common, but we do get these type of patients as well with splenic vein thrombosis, with splenomegaly and hypersplenism. Not very common, but we do get these type of patients in chronic pancreatitis as well.
Right. So what do you think you would do next in such a patient? This patient is symptomatic, has pain. The pancreas, as you can see, is showing stippled calcification. There is a dilated duct that is seen in the tail and partly in the body. If I may just point out, this seems to be a dilated duct out here, tortuous out here, stippled calcifications, and of course, extensive varices. But there is no history of a previous bleed. I mean, there is no history of either a variceal bleed or melena. How would one tend to proceed with these patients?
So usually in patients with sinistral portal hypertension, even if there are gastric varices, unless the patient bleeds, splenectomy is not indicated. But in patients with chronic pancreatitis, when we are contemplating surgery for chronic pancreatitis, we do have to do splenectomy as well, because it has been shown that even if these patients are asymptomatic in terms of hematemesis or melena, in terms of symptomatic gastric varices, we still have to go and do a splenectomy when we are doing surgery for chronic pancreatitis. And
yeah, I agree. I entirely agree with you. Mehul, Ankit, anything from your end apart from an upper GI scopy?
I think from our side, an upper GI scopy to assess the varices, and especially if the patient has had previous bleeding, you can consider endotherapy at that point.
Correct. But in the setting of chronic pancreatitis, if you are planning a resection, we would rather, deal with the spleen and the varices at the same time, because this is one of those few instances where you do a splenectomy, as Dr. Lakhe rightly said, sinistral left-sided portal hypertension, the fundic varices would just disappear over a period of time.
Right.
Yeah.
That's all.
Right. Yeah. Prasad Pandey. Your thoughts, how would you plan? Of course, I mean, the picture is quite there right in front of you. Anything different you would do in this patient, or you would just do a left-sided resection and be done with it with a splenectomy, or would you want to open the duct as we have done out here
Yes,
after
sir,
a
definitely. Definitely, because the duct looks dilated, and it being a hard pancreas, staple closure is not really very good way of addressing the duct. So I would rather open the duct, go on to the parenchyma, maybe a couple of centimeters towards the body side, and attach a loop of jejunum there. So I would rather have a pancreatic jejunostomy rather than just a pancreatic stump.
Yeah, that's exactly what we did. But as you can see, it's a difficult anastomosis because here you have a
Yes.
duct that is completely cut off, and it's an open-ended duct out here. You have parenchyma, but that is below the duct, so becomes a little bit of a tricky anastomosis. That's what I think I want my surgical colleagues to understand, that this anastomosis is not a very easy one to do. Sometimes you can have kind of a post-operative event of a leak. We were fortunate we did not. And of course, again, management of the distal pancreatic stump, if it's a stapled closure for hard pancreas, but for soft pancreas, we would rather also individually kind of close the duct.